Hi, today we're talking with Dr. Ethan Forsgren, a consultant with the Iowa Primary Care Association, about medication management, community partnerships, and the roles that they play. Dr. Forsgren, can you tell us a little bit about your history and your trajectory in healthcare?
Of course, yeah. I'm an Iowan. I grew up in this state, and I went to medical school here at the University of Iowa. I also have a master's in public policy from Harvard, and I've been consulting with the Iowa PCA for a few months now, working on their behavioral health strategy, like you said. This is the job that comes to me after some time. Before I went back to school for my graduate degrees, I actually used to work in a lot of emergency medical education, both domestically in Minnesota and also internationally in South America, in Venezuela and Bolivia, building paramedic programs. And some of that work is what brought me back to Minnesota to begin working on a project called community paramedicine.
Okay, Dr. Forsgren, for our audience, can you maybe explain more about what community paramedicine is?
Yeah, so community paramedicine is an idea that was really born out of the deep need for some type of in-person care in very rural and hard-to-reach parts of the country. It was born a few times, as many, I think, good ideas are. First in the Australian outback, actually, also in parts of rural Texas, and even in the northeast parts of the country on a small island off the coast, where a number of older individuals rarely were able to make it to go see their primary care doctor, and there were very few people who actually went out to the island, and one of the people who happened to do that is the paramedic, because of course emergency medicine services have to reach everywhere. And so they began to wonder, could this paramedic do a follow-up visit for some of our primary care physicians or primary care providers? And out of that started to grow this idea of using paramedics not in an expanded scope of care, not doing things that they don't already know how to do as paramedics, but in an expanded role to use those same skills and apply them in a way that is more primary care focused and tries to integrate with the rest of the patient's care team.
So what was your specific experience with community paramedicine programs?
Yeah, so I came back to Minnesota and was working as a researcher at Hennepin County Medical Center, where I was in league with the director of their EMS service. And he was really excited about community paramedicine. Community paramedicine had just in 2011 been approved through a lot of hard work in the Minnesota State Legislature to approve a small reimbursement code, a CPT code, to pay for this new type of provider, a community paramedic, to provide primary care services with patients in the field. And so it was a nominal sum, but he wanted to start a program because he believed that this is what patients needed, and there was a high demand, especially from people who were high utilizers of the emergency department at Hennepin County, that there were people that we knew we wanted to meet before they had to come to the ED.
So today we're going to be talking about medication management within the community, but before we get there, what are some additional roles that you did before that?
Absolutely. I think there's a few different things that a community paramedic can do. Medication management is one of them, but we also did a lot of wound checks for patients who might have diabetic foot wounds or something, or need their bandaging changed. We also would even do things like deliver food. Hennepin County had a special program with its food bank in order to deliver food to patients in their homes. We would help bring patients to their primary care visits if they needed a ride. And we would do medication management, literally filling pill boxes and helping patients manage what could be dozens of medications in their closet. What that really means for a community paramedic is sometimes bringing a medication to somebody if they aren't able to go to the pharmacy themselves, filling their pill box with medications with the help online, we say, over the phone with a pharmacist.
Can you give us some examples of issues involving medication management that you encountered in the field, where this issue started, and then how the interventions you provided played out?
Yeah, I think patient stories tell it best. For example, I think very few providers, when you're inside a clinic or inside a hospital, realize what somebody's lived environment looks like inside their home. Sometimes we would go into a home with a community paramedic. I remember one woman, she lived on the 20-something floor of a large high-rise. It was very difficult for her to get in and out, very difficult for her to take out her trash, for example. And she had literally trash bags of medication in her bathroom that were full of old pills, pill bottles, and that she was trying to understand how to take. Quite very stressful for her. People kept sending her home with medications, and she would add them to her inventory. And so this person had heart failure. It was very sensitive how to manage her blood pressure with so many anti-hypertensive medications. And it took us at least an hour to sit there and go through all the medications in the bags in her home, and help her dispose of the ones that had expired and help her organize the ones she needed to take for the next year. And I think she, as well as many other heart failure patients who became a priority for our program, I think we saw maybe like a 50% reduction in emergency department visits over the course of 12 months for those about 10 patients.
That's impressive.
Yeah. Another example might be a man who lived on the south side of Minneapolis. He only spoke Spanish, he didn't speak English very well, and he had been recently seen by a primary care provider at one of Hennepin Health's clinics, and had been started on his insulin for his diabetes. And anybody who's had to take an insulin injection knows that can be rather complicated, and it's not super intuitive. And it could be very precise and manage that very closely as you check your sugars and take your medication. And so this person had been educated in the clinic about how to use their needles and syringes and their insulin and how to store their insulin. But sometimes one training is not enough. And so this patient went home, and the primary care doctor at that place realized, I'm not super confident this person knows what they're doing. We've asked him to come back. I haven't heard from him in a while. Could you go check on this patient for us? And so we were able to. We had a translation service with a phone, make contact, visit the person in their home, check in, make sure that the insulin was in their fridge, that they knew how to check their sugars, demonstrate it, sit there with them as they checked their sugars and took their insulin. And we did that multiple times with that patient. And it's really about that relationship that people are able to make. A community paramedic's not the only person who can do that kind of relationship. I think there's a lot of other people, and I hope we can talk about this, the fact that there are also home health nurses, other people who go to the home and do similar work. But sometimes patients aren't eligible for those services because of their insurance status or because of their citizenship. And the community paramedic found itself to be kind of a critical resource for such patients as a way to improve their health and to, avoid unnecessary hospitalizations and costs.
Great. These are wonderful examples. Do you have any advice for a community or clinic or any entity that is interested in starting some sort of partnership or program similar to this or improving upon the one they have?
Yeah, I think there's a few things come to mind. One is be patient. I think a lot of people are very eager to start, and I think you have to start with a lot of listening to the other providers who are also interested in doing the same work, who are maybe experiencing the same frustrations. As I mentioned, there's a lot of home health nurses who also do similar work in people's homes. And if you move too quickly, people become very suspicious, and they are very concerned because you're entering into a role that they've also occupied. I think the need everybody realizes is greater than any of us are providing at this time. Just the systems we work in has not allowed us to provide the holistic care that we want to for all of our patients. But you need to build your team, and you need to trust each other. And so we actually spend a lot of time listening to nurses, listening to other social workers and people who touch these patients, just so that we could cooperate with them, hand patients back and forth. Sometimes a patient might qualify for 60 days of home health services, and they need to come on to our service so that we could follow up because they only got 60 days of home health. And so we would have to pass patients back and forth like this, and it took a lot of trust and collaboration. It takes patience to build those relationships. Another thing is payment. How do you pay for these services? One constant frustration for our program was the very small nominal reimbursement we got every time we saw a patient. When you're working with that kind of reimbursement, the talk always starts to then turn to cost avoidance. Can you prove that you're saving costs for a health system? And it was actually my charge when I was part of this program to actually do the business planning and try to prove that this program was saving money. And I did the best I could. But the program struggled and probably still struggles because it's like trying to balance two payment systems, fee-for-service with these new value-based payment models. But in Minnesota, we used a saying that transferring between fee-for-service and value-based care is like trying to step between two canoes in the middle of a lake. One canoe is very big, fee-for-service. We've built our whole systems around this. The other canoe is very small. It's value-based care, and it can't support all of your weight all at once. And so it makes for a very delicate transition. And the problem is that with one foot in each canoe, you're still tied to fee-for-service. So even if you can decrease admissions, even if you can prevent somebody from coming into the ED or having a heart failure readmission into the inpatient wards, you would inevitably lose money as a healthcare provider for that. And so if we could prevent these things, we lost money compared to the amount of benefits or incentives we would win for having cut down our readmission rates.
Thank you. Are there any resources you would recommend to our audience as they start to explore these kind of initiatives?
I think if anybody wants to learn more about community paramedicine, I think it's worth looking up across the northern border at Minnesota just because they're very local, also very rural applications of community paramedicine. And there's a lot of people who have recent experience with building programs and also trying to get the framework for some reimbursement mechanisms built into their Medicaid.
Dr. Ethan Forsgren, thank you so much for speaking with our audience today on medication management and community paramedicine.
Of course.